All right, good morning, everyone. Thank you so much for joining us. I'm Dawn Johnston, and I'm the Director of Development for the Providence Brain and Spine Institute, and it's my pleasure to welcome you to today's program, Restoring Function with Minimally Invasive Brain Surgery, featuring Dr. Seth Oliveria. Thank you for joining us. As a member of the Providence Foundations of Oregon, I have the joy of working with Dr. Oliveria and his colleagues to ensure that they are able to provide innovative care and pursue their research efforts for years to come. Several of you on the call today have supported this work, and we are so grateful to you for the investment you've made. Thank you. The Providence Foundations of Oregon began the virtual series Doc Talk in early 2021 at a time when it was impossible for us to safely meet in person. And we've continued to offer these programs to our patient and donor community because they're so accessible. They were created to bring awareness and highlight how the revolutionary treatments, research, and community support efforts fueled by philanthropy are bringing hope to more patients in Oregon. Our physician speakers welcome general questions, but are unable to offer specific healthcare advice to individuals and instead encourage guests to follow up with their primary care provider. A couple of housekeeping items before we begin our program. Dr. Oliveria has a 30-minute presentation with about 15 minutes for Q&A at the end of the program. If you've participated in Zoom meetings in the past, you might notice this one is a little different. Only the speaker is on the screen and has speaking abilities, but we'd love to hear from you, and we'd like to ask you, and if you'd like to ask a question, please use the Q&A tab that's found at the bottom of your screen. And you might be able to notice that if you run your cursor across the bottom, you'll see something that says Q&A. This is different from the chat, but you're welcome to use either one for questions. And if you have difficulty utilizing that, you're also welcome to email me directly during the webinar at dawn.johnston@providence.org. Today's program is being recorded, and we'll be sharing the link to the recording with you by email, so please be on the lookout for that. Now, I'd like to take a few minutes to briefly introduce Dr. Oliveria. Dr. Seth Oliveria received his undergraduate degree from Linfield College in McMinnville, where he also met his wife, Stephanie. He then earned an MD and a Ph.D. in neuroscience from the University of Colorado. He completed his neurosurgical training at the University of Florida, including a fellowship in stereotactic and functional neurosurgery. He performs general cranial and spinal neurosurgery and is particularly interested in deep brain stimulation, trigeminal neuralgia, brain tumors, and the surgical treatment of epilepsy. Outside of work, Dr. Oliveria enjoys fly fishing, training his German short-hair pointers, and is theoretically training for a half marathon. At this time, I'd like to invite Dr. Seth Oliveria to join us on today's call, Restoring Function with Minimally Invasive Brain Surgery. Dr. Oliveria?
Hey there, you can see me and hear me okay? Well, thank you guys very much for the warm introduction. As Dawn said, I know that my position was recruited, with the generous support of the foundation. I'm very appreciative of that. And the foundation was very instrumental in my being hired for a new position in functional neurosurgery. And I'm really pleased today to have a chance to speak about some of the things that we've achieved in the time since I have joined began the functional neurosurgery program at Providence, and I'm going to talk about some of those things here today. As Dawn mentioned, so my talk is about tailored minimally invasive brain surgery, and I'm going to really discuss that in the context of three different conditions: epilepsy, brain tumors, and movement disorders, and really, for all of those conditions, brain surgery is really a daunting hurdle for people to get past. And I'm going to describe today several state-of-the-art techniques that we use to help to reduce the time that patients spend in the hospital, and also to accelerate the recovery and to reduce risk. And hopefully by doing that, the goal is to reduce the perception, or to change the perception that this is a is that daunting hurdle, and hopefully people can see this more. The goal is where it's one small, important but small step in their recovery process from the condition that we're treating. So I'm going to start with epilepsy, and I should say specifically we're going to talk about focal epilepsy coming from one part of the brain. There's a whole nother set of epilepsy called generalized epilepsy that comes from all over the brain all at the same time, and that's a different subject. The goals of epilepsy surgery are to first identify where seizures are starting from, and then to determine whether we can remove this area safely. And if so, if we can remove, destroy, or disconnect that area. And if it's not safe to do that because of the location of the brain, then we might consider neuromodulation, which is using electrical stimulation to control someone's seizures. And so the gold standard for surgery for epilepsy is resection, to remove an area of the brain that seizures are coming from. And I always tell my patients who have this condition that it's somewhat like the difference between a bomb and like a sniper, that, if you use a bomb, you can sort of, cover a bigger area and a better chance of hitting your target, but there's more collateral damage compared to a sniper shot that can be very focused and take out the target, but, has a bigger chance of missing. So we know that the more brain you take out, the better chance of controlling seizure, but there's also increased chances of side effects that can be significant depending on the part of the brain we're talking about. And for today's talk, we're really going to focus on temporal lobe epilepsy. That's the one that we understand the most and have the most experience with, and similar principles apply to other parts of the brain, but several cases we're going to show different approaches to temporal lobe epilepsy. So this is an example when I first started 5 years ago here, how we approached these cases, and it's mostly for comparison to what we're doing now. So this is a young mother who was having several seizures per month despite maximal medical therapy. And as you can see here, we put her through a big surgery. I don't know if you can see my cursor here, that we took off a large piece of the skull. And this is a reconstruction of her CAT scan. You can see that we laid a grid of electrodes on the surface of the brain that's shown here. And there's also deep electrodes to the deep structures in the brain. And we did that as a first surgery, and then we kept her in the hospital for about a week and weaned her seizure medicines, and were able to capture 7 seizures that all looked like this. They're all coming from just specific contacts inside the brain. And reliably, the seizures are all starting from the same place in an area called the hippocampus in her brain. And so then we took her back for a second surgery where we took out all these electrodes, and that's shown here. And we ultimately did what's called temporal lobectomy, where we took out a selective part of the temporal lobe, including those deep structures where we found that her seizures were coming from. And she went home 3 days later, and she's had no seizures since then in 2018, which is wonderful, and that's an excellent result. But that being said, this surgery is quite painful. As I said, she was in the hospital for a week with a portion of her skull removed, and that surgery hurts. And she, had headaches for quite a while after the surgery, and ultimately did very well. But that's a very aggressive surgery, and I would say that it takes a motivated patient and a motivated epilepsy doctor to send that patient to me for surgery, and not everyone's going to agree to that, even if they are a good candidate for it. Now I'm actually going to show a short video of another patient who had a similar kind of aggressive surgical procedure. He actually went through 3 different surgeries, and I'll let him describe that.
Left side of the head, they obviously had to take off a good section of the skull, a couple inches in diameter across, but a fairly decent sized piece of brain.
But Ryan Bice does not miss that couple-inch chunk of his brain, nor the daily epileptic seizures that were part of his life for 8 years, sometimes several times a day.
Kind of blank out for a split second or a few seconds.
Ryan has not had even a hint of a seizure in the last 17 weeks, thanks to Providence neurosurgeon Seth Oliveria. In a first surgery, Dr. Oliveria placed these spaghetti-like electrodes in Ryan's brain to monitor his seizures and to figure out the precise source of the seizures, whether they were coming from deep in the brain or on the surface. In a second surgery, these small round electrodes pinpointed the exact area.
Okay, these electrodes right here are the ones where his seizures were coming from.
It was a eureka moment followed by a third and last surgery.
It was an area that we could take out without causing him to neurologic problems.
As amazing as this surgery is, unfortunately, it works for very few patients with epilepsy.
And so it works for him because there's one area that was misbehaving and we could take that out. Not the case for everyone.
Ryan knows just how lucky he is and says his life feels almost limitless now. He hopes to start driving soon.
All in the world.
The only telltale sign of Ryan Bice's brain surgery? A slight divot in his head. Marilyn Deutsch, Good Day Oregon.
So again, that's a patient who had a wonderful outcome. We put him through a lot. We put him through 3 different surgeries to help localize and ultimately resect the part of the brain where he was having problems. And again, that's, and some people still need that procedure, but as we do these surgeries, I always felt, that I was hoping that we could do things to make it easier for people and more approachable.
Well,
and so, that leads us to really kind of a more modern treatment that we're using. We lean on very heavily for seizure surgery now, and that's called laser ablation. And what this entails is these plastic catheters shown here in the bottom right, that we can put a fiber optic cable down this catheter, and then it has a cooling jacket that we pump saline through to keep it cool, and that allows us to do procedures where we can do a real-time MRI while we're burning an area of the brain that's involved with seizures, and I'll talk about this as well for use in brain tumor surgery here briefly, but it's really revolutionized epilepsy surgery. So for example, this is another patient with a problem in a similar area of the brain, in the hippocampus and the temporal lobe. There's an arrow there. It's a very subtle finding, but if you compare this side of the brain to this side over here, there's a slight scarring of this structure. And with a lot of other testing that I won't go into now, we are able to with high confidence determine that that's the area of the brain where this patient's seizures were starting from. And then, so what happened? I actually want to take one step back, that these surgeries are done in the intraoperative MRI suite that we have at St. Vincent's. And it's really quite a remarkable surgery that we put these probes into the brain in the operating room, which in this picture would be on the opposite side of the MRI scanner here from the control room. And these patients can actually have a CAT scan and an MRI and have surgery all in the same location. And sort of, the bed doesn't move, but all these kind of complex pieces of equipment come in and out of the room around the patient to get the job done. And so this is what it looks like in the MRI scanner. These pictures on the left show real-time heat information that we're using to burn that area of the brain, and the pictures on the right show a computer estimate of the cumulative damage that we're applying to the brain to effectively burn this area where the seizures are coming from. As you can see, we're kind of pulling that kind of catheter back along this trajectory to create a spherical lesion, and we can do more complicated shapes if we need to with multiple catheters, but this is very typical. And this is what it looks like at the end. We intentionally burn this part of the brain where the seizures were starting from. And what's really remarkable about this is we do it through a little 2mm incision. Essentially take a knife and make a little poke hole in the skin, and then put that little kind of bolt that you saw into the skull to hold the catheter. And it's all done through incisions that are realistically that big. And this patient is very typical that she had very little pain, used a little Tylenol, maybe a little bit of pain medicine the day after surgery, no new problems, was discharged the next morning after surgery, and has had no seizures since then. And I have one other video I'm going to show, let her describe her experience.
I was having 8 to 10 seizures per month. My seizures went away completely after the surgery. I had no idea that this was going to help me this much. Had I known, I would have done it years ago.
Yeah, so this really represents a real kind of breakthrough for neurosurgery. It allows us to do surgery through the smallest possible incisions and can treat very serious diseases in a very minimal invasive way.
And Sylvia said something that I hear over and over again, which is if I'd known, I would have done this so much sooner. That's a very common kind of thing I hear from our patients, especially with these minimally invasive techniques. And so now this is, a little bit more of, this is a recent surgery that I did on a patient. And this is sort of, represents our more kind of current approach to mini surgeries for epilepsy. And what you see here is that instead of using that blanket kind of grid electrodes where you have to take off a big piece of the skull, we're using these percutaneous electrodes. They go through the skin and through the skull with these little kind of holders, these metal bolts that go into the skull. And we put in these electrodes that come through and still go into the brain. It's still, an invasive surgery for sure, but these are much more comfortable than the big surgery I showed you at the beginning. And, while people certainly have some discomfort from this, it's not particularly, it's not, most people say it's sort of minimally uncomfortable and, may use a little bit of pain medicine. And what's really remarkable is through these same ports that we put the electrodes in, when necessary, we can actually thread the laser catheters down that same trajectory into the brain. So in this patient, we found that their seizures were starting where these two electrodes come together. And so what we did then is we took out all the electrodes for her second procedure and threaded the laser catheter down that same trajectory of this long electrode here. You can see that in this bottom picture. And we're able to basically without performing any more incisions in the scalp or any more holes in the skull, we were able to burn that area, exactly where we found our seizures coming from on these electrodes. And so really, and again, she went home the next day. She's pretty early after surgery, but everything went very well. And so, as I kind of alluded to at the beginning, not everyone is a candidate for a resection or a laser ablation of the area, because we know some areas of the brain are important and do important things. And so this is an example of a device that we use for when we can localize a seizure, but we know we can't take that area of the brain out. This is called responsive neurostimulation. This device is called the NeuroPace device. And what is really remarkable, it has electrodes that go into it that monitor brain activity. And the little computer, and it's housed with the battery here. If it detects a seizure, it applies current to abort the seizure. And this is an example of a patient who had seizures starting from a similar area of the brain, the hippocampus, but on her preoperative testing indicated that we couldn't take that area out without causing her significant issues with her thinking, particularly with her memory. And so we instead implanted this device with two electrodes down into that area, and she's done quite well with reduction in her seizure frequency and severity. And the neat thing about this is over time it can get better as we essentially tune the device to better detect and better respond to seizures. And so oftentimes over the course of several months or even several years, seizure severity continues to improve. So I'm going to change gears now and talk about brain tumors. And so this is an example of a patient with, unfortunately, a malignant brain tumor. And this is in a part of the brain that is quite deep, not at the surface. And, for patients like this, it's similar to kind of what I said at the beginning, that these patients come in with, that they've been told they have a brain tumor, which is, stressful and serious. And this patient, their tumor happens to be underneath the motor areas of the brain that we're worried that if we were to kind of go straight in there, good chance of hurting them and making them weak on one side of their body. And he actually presented with some mild weakness and clumsiness on the left side of his body. And so we did some advanced imaging on him. This is a representation from the motor cortex, how the motor fibers in the brain travel around the tumor. And this tumor effectively is splitting those motor fibers that are going from the motor cortex of the brain down through the brainstem into the body. And so we knew that this is a high-risk tumor to take out through traditional means without causing damage to those motor fibers and making him weak as if he had a stroke after surgery. And so we use these kind of devices. These are these tubes that can be used to kind of split some of the brain tissue as minimally invasively as possible. And we use this sort of advanced imaging to avoid those important, but effectively invisible structures within the brain. And this is what it looked like afterwards. And so I should say, not only do we use these little tubular retractors to make a really minimal pathway through the brain, avoiding these fibers, we also are able to test these fibers during surgery by stimulating them and looking for motor responses. And we did this with the patient asleep with what's called neuromonitoring to detect those responses in the muscles. And this is what it looked like afterwards. So we were able to kind of resect that tumor. And, again, we found like right along this front edge of the tumor was where the motor fibers of the brain were at. And he did quite well. He had some very mild worsening of his left-sided deficits after surgery. We expect from stretching those areas, but he went to rehab for a week and then home. And so that's sort of the example of sort of a minimally invasive open surgery. And I'm going to then, which in his case, I think was important to get the job done. But for some patients, we can, take it even a step further. And again, use those laser probes like we talked about. And so that patient I just discussed, it was an example of a malignant brain tumor. And we know, unfortunately, that what makes those tumors so nasty is that they come back, predictably. And when they come back, when they recur, as it says here, oftentimes, unfortunately, survival is, on the order of 6 months after recurrence. And so we all hope that we can do more for those patients to help kind of prolong their survival from the recurrence of their brain tumors. And so, doing surgery for recurrent brain tumors is somewhat controversial. We know that if we do repeat surgery safely, that it can, increase a patient's, lifespan. But, there's increased risks from doing redo surgery for brain tumors. And so there's a delicate balance there. And so laser ablation represents sort of a desirable option for those patients as well, that, we can do a very minimally invasive procedure to help control kind of, growth of their tumor. And we do it again through these little tiny incisions. And that's what's shown here. This patient had a prior resection of part of a brain tumor. And then you can see on the edge of that, the tumor has come back, and then it was ablated here safely through using a laser. It also is desirable for patients who present with very deep malignant brain tumors in areas that we can't safely take out. And this is an example of a tumor that's deep within sort of the deep nuclei of the brain. This is an area that we traditionally wouldn't operate on through open surgery because the likelihood of new kind of serious problems after that surgery would be very high. But using a laser, we can put that down there and burn that area with a minimally invasive approach, and patients tolerate that well. And so those were malignant brain tumors, which unfortunately are quite common. Despite our best efforts, those always come back. In contrast, for low-grade tumors, we can use laser ablation to reach tumors that we couldn't otherwise, and can be potentially curative. So this is an example. This is actually, if anyone had attended Dr. Deschmuck, my partner's talk from last year, he showed this case because it's somewhat of a remarkable case. It's a patient who had a brainstem low-grade glioma that was initially seen by one of my partners and followed. He was, young man. He was very healthy. He ran frequently. He did long distance running. I think he also participated in triathlons, and developed sort of gradual onset of some problems with his some subtle weakness and some problems with his swallowing and eye movements. And he was found to have this tumor in the brainstem, which is sort of the highest priced real estate of the brain, and an area we traditionally don't operate because we just know will make people worse. But using a laser ablation catheter, we were able to reach down there and burn that spot in the brain. This was definitely a high risk and not a typical surgery. But first, he was told, this tumor was growing over time, and he was told this was going to kill him. And we were able to treat it successfully. And this is what it looks like afterwards. And so this is his pictures before surgery on the left. And on the right, you can see there's a little scar there. This is 2 years after surgery, and this is gradually involuted over time and with no evidence of further growth. And this is just another example of a young lady who presented with a tumor. And again, this is a difficult area to reach because it's right under the motor areas of the brain again. And is something that sometimes we would treat that with open surgery, but pretty high risk of her having significant weakness after that surgery because of its location, relative to the important motor areas of the brain. And so I looking at this tumor, it had sort of some cysts around it that I thought would protect us. We could heat that area up safely. And we took a laser catheter in through one of those cysts and down deep into that. And we burned it. This hasn't been very long, only 6 months, but that again just shows this little scarred area, and we're watching that closely. And so far, it's just kind of gradually kind of shrunk over time, and there's been no evidence of growth. And so to change gears, so we're kind of going to more and more or less and less invasive. And so really to shift gears even again, We commonly, there's another kind of type of procedure I'm involved with, along with a radiation oncologist, is what's called gamma knife radiosurgery. And this is a procedure where we put this kind of device on the head to hold it still, and we use lots of beams of low dose radiation that's effectively harmless to the rest of the brain, but they all crisscross at one spot, and that spot gets a very high lethal dose of radiation to the tissue there. This kind of head frame fits into this device here, and that you go into the machine. That's where the treatment occurs, and you don't feel anything, you don't hear anything, but it's kind of, in a very precise way, we can expose brain tumors to radiation treatments. And we use it very, very commonly for brain metastases, tumors from other parts of the body. This is a young lady in her late 20s who had metastatic melanoma. You can see here, here's a metastasis from elsewhere and from her primary tumor that landed in the brain. You can see 8 months later, after her gamma knife treatment, that tumor had disappeared. We use this for a variety of treatments. We also use it for slow-growing tumors in difficult to reach areas like meningiomas and schwannomas. I'll also talk a little bit at the very end about functional lesions that we create for essential tremor and for facial pain. I'll come back to that at the end. And so speaking of, we're going to switch gears again here and talk a little bit about movement disorders. And I looked through our list of patients. It's certainly several of our patients on the call are well familiar with these types of procedures. And I welcome you guys for joining in. So I'm going to talk specifically about deep brain stimulation. This is a treatment that's been around for a long time, in particular for Parkinson's disease. We also use it to treat essential tremor, dystonia. More recently, it has gained approval for specific types of epilepsy. And there's many kind of news stories about other investigational indications and targets in the brain that I won't go into a lot of detail today. But each of these different movement disorder conditions have different locations in the brain that we stimulate with tiny probes. And as you can see here, this is sort of what the device looks like. This is actually the old-fashioned model. We have newer ones now. I need to update this slide. But you can see this is the business end of these electrodes that go deep into the brain, into those structures that we talked about on the last slide. And then the wires run down the neck to a pulse generator, or often commonly called the battery, that sits in the chest, similar to a cardiac pacemaker. And so, really the most technical part of this is making a trajectory through the brain safely to hit those targets. And the targets that we're aiming for, in movement disorders are very small, in the order of about 2 millimeters, smaller than a pea. And so we do this very, very accurately and precisely. And these days we're starting to use similar to that brain tumor case I showed. We're using this high complex imaging that lets us see these sort of fiber tracks through the brain to help us better target the appropriate place, like it shows here. It's difficult to see, but the crosshairs are right on this fiber bundle where it comes into the nucleus of that location in the brain. This is specifically for essential tremor. And we use this sort of crazy looking device shown here. This is what's called a stereotactic head frame that allows us to very precisely hit that target in the brain. We essentially can translate that computer plan on the MRI into real space using this device. And this is, shown for DBS here. And this is, this picture on the left is during a surgery. This picture on the right is a model. And I should say that we use this same device for all the procedures that I've shown previously, like putting in electrodes and laser ablation catheters very precisely as well. And DBS is famous for awake testing that we perform with the patient awake and participating during the procedure. And the reason for that is that we want to hit these targets very precisely with and confirm that we're hitting it, and the patient's getting benefit from that, and also to avoid side effects, because not only is these tiny targets in the brain that we're trying to put the probes into, but also right around that there's lots of other important structures, and if we accidentally stimulate those other structures, that people have side effects that really limit the benefit of the device. And so, the problem with awake testing is, that's sort of stressful for patients. Most patients are actually quite comfortable, and I always say we can get almost everyone through the procedure. But, again, it's a big hurdle to kind of consider going through awake brain surgery. And, I think there's certainly a subset of patients who wouldn't do the procedure, who would be very anxious, so even if they agreed to do it, because of the idea of having surgery, with kind of this process going on. And so there's definitely been a lot of interest in a sleep DBS surgery. And, so what that then entails is either using this as a CAT scanner, or again, we can use an intraoperative MRI scanner to see exactly where those electrodes are at in the brain. And then what we do is we take, this picture shows the electrodes in the brain on a CAT scan, and we can merge that into our preoperative plan and make sure you can see these kind of bright white spots is where the electrode is at, and make sure it's right down the barrel of the plan that we intended, and basically kind of confirm that our intended plan and our real plan and real space line up with each other. And when they do, and then kind of these bright spots are right on top of the colored lines that we planned, then that's a bullseye. That being said, anyone who does these types of surgeries can tell you that the structures are so small that even when we get a bullseye, sometimes we don't. There can be unexpected side effects. And so this is an example of a patient that I did with an awake testing. And as you can see, the white spot of her electrode is right on top of the plan, right exactly where I wanted it to be. This is sort of representation of this part of the brain, the thalamus, and there's this kind of circle here that it's about 2 millimeters in diameter, and that's about the size of the target. And there's kind of representations of all kinds of important brain functions and all these kind of subnuclei around there. And in particular, the one behind it is the sensory nucleus of the brain. This is one of the motor nuclei that we intend to stimulate. Just behind that is the sensory nucleus. And so if you're a little bit too far back, you'll get stimulation of that sensory nucleus, and people usually kind of feel like tingling or unpleasant feelings from that. And so this patient, even though it was right where we wanted it to be, when we turned on the device to test it in the operating room, she said, oh, wow, she felt this kind of buzzing in her hand and her face. She did see, despite that, she saw a really good improvement in her tremor during the surgery. But what we did is we pulled it back, 0.5 millimeter, a tiny increment. And she said, oh, now the tingling is not too bad. And I still can, tell that my tremor is better. And they pulled it back another 0.5 millimeter. So a total of 1 millimeter, this much. And you could, and she's then still had good control of her tremor, but all those kind of uncomfortable sensations went away. And this is that patient before surgery. Here's her handwriting. This is immediately in the postoperative area. She was a very avid writer and wrote in journals all the time. And so this is, in the post-op area, this is her writing in her journal, and really remarkable. And she's had, she still sends me letters all the time. And so I can confirm that she still has very good handwriting years later. This is an example of a patient. Again, this is that same sort of representation of the thalamus, and that's sort of depicted here with this kind of colored line. And then and this dark thing is the electrode here on an MRI. And this is a patient who had their surgery done at another center with completely asleep DBS, and they had really good results on one side of the brain. The other side, they didn't have very good results, and it turns out the electrode is just outside of this structure. And this is an example. So we brought her back to basically revise that electrode and move it from this spot here to this little circle here is where we intended for the electrode to be, moving it effectively about 2 millimeters in the brain. And this is her in the pre-op area. This is her tremor, which is pretty remarkable. And then we move that electrode about 2 millimeters in the brain, and this is her after surgery. And you can see, real dramatic improvement in her symptoms. And this is with the device on, but not quite in the right spot. And so just to kind of highlight the importance of that testing. But again, as I said, not everyone is excited about having awake brain surgery, if you can imagine that. And and as much as it's kind of interesting, and I think it's valuable to do that awake testing, I also understand that we want to make this sort of safe and effective, but we also want to make it easy on patients. And so we've really done a lot of research recently into doing the same testing that we would do awake with people under general anesthesia. And so this is an example of a patient that we did some motor testing with them under anesthesia. And this is a representation of all the different motor kind of muscles in their face on the top, and then their hand, and then their leg on the bottom. And it's a little bit hard to see probably, but you can see on one side, the electrode is right where we want it to be. And there's no when we turn it on, we don't see any motor activation. On the other side, it's just slightly posterior to our intended plan. And when we did that, as we sort of turned up, you saw just very selective activation of the muscles in the face. And that, was an indication we needed to adjust the electrodes slightly. And we did that and the patient did well. And even more recently, I've been working on doing similar things. One of the things that's really difficult to test with someone asleep is if they're feeling anything, obviously, because they can't tell you that. But we can still apply sensory inputs to the hands and the feet that they would feel if they were awake, and we can detect that in the sensory areas of the brain, which is shown as these waves. And we can actually show that if we stimulate the sensory areas of the brain, we can suppress some of these sensory signals reaching the brain at the conscious level, even though the patient's asleep under anesthesia. And so we've been working on this, and this kind of active area research that I'm very interested in. Again, but if we can kind of do all the same testing without, the patient's involvement, that's just safer and more comfortable, and ultimately just sort of increases patients who might be interested in the surgery. This is just an example of what the healed incisions look like after surgery. This patient had just the perfect type of hairstyle to make this so we could actually see his incisions. Oftentimes with folks who have kind of a full head of hair, you can't see any evidence of the electrodes after, or of the incisions after surgery. And this is the chest incision. And we do, again, the same thing as we try to put all the hardware as much deep into the kind of tissue and for in the skull. That means we actually drill out little spots for all that hardware to sit inside the skull, recessed, instead of sticking out over the top and making bumps in the skin. Sometimes we're limited. Some people have thicker skulls than others, and sometimes we don't have that option available to us. But as much as possible, we try to put everything deep in the skull. And one other key thing that we do is that when you do awake surgery, classically we would put the electrodes in and then come back for a second surgery to put the battery in the chest and to run the electrodes down the skin, because that part hurts. You have to be under general anesthesia for that part of it. But by doing the surgeries with people asleep or mostly asleep, we can do it all in a single stage, which really makes it much more sort of approachable for patients. And just to kind of finish up here briefly, the last thing here is that, if you've been on sort of a flight on Alaska Airlines, you may have seen this ad. This is from our sister hospital up at Swedish in Seattle, using gamma knife treatment for essential tremor. I'm not going to go into a lot of details about this, but just to say that for people where DBS is not a good option, we do have other procedures. And this is an example where we did a little kind of gamma knife lesion with radiation to treat the same spot that we typically stimulate with DBS. And this was her kind of handwriting and kind of drawing a spiral before and after the gamma knife treatment. So just to conclude, I hope you guys have had a chance to appreciate some of the things we've been able to achieve during my time at the directing the functional neurosurgery program at Providence Brain and Spine Institute. A very close partnerships with the epilepsy team, the movement disorders team, and the neuro-oncologists for all the procedures that I described today. And there's been significant accomplishments in each of those areas. That we have a sort of a level 4 epilepsy center, which is the highest level epilepsy center, thanks to our epilepsy surgery program. Our movement disorders program has expanded. We hired both a nurse coordinator, Teresa, who many of you may know, and then we also recently hired a nurse practitioner, programming nurse practitioner, to program all these patients, to basically optimize their devices after surgery. And in neuro-oncology, we recently recruited Dr. Prakash Ambadi and his entire team, who have really expanding our neuro-oncology program. With these accomplishments, there's several new areas that we and opportunities, but as well as challenges that come with that. And so the kind of 3 areas that we really focus on, I think you can probably appreciate from this talk, there's a lot of technology. That technology is expensive. Things like intraoperative MRI machines, are expensive. The laser catheters are expensive, and that technology keeps moving, just like your kind of your iPhone or your computer. That things keep on improving and making some of the old technology obsolete. In particular, that aiming device, that big head frame, is sort of going to become obsolete in the next 2 years, and we have to replace that with something. And that's sort of a big kind of piece of equipment that we kind of will probably need more help from our foundation. And so you'll probably hear more about that. But that actually represents one of the most significant kind of risks to the program going forward is, kind of continued sort of investment in technology. I'm happy to talk more about that. We're very focused on training. We're doing all these neat things. And we want to share that with the next generation. And we're in the process of developing a fellowship. And, we have to kind of, the fellows cost money and things like that as well. And we want to be able to kind of give them a rich environment that's worthwhile so we can, we can recruit the most, kind of the best and the brightest, candidates for that. And as I alluded to just a little bit, research is what really drives all these procedures, kind of innovations forward. And we're very interested in that as well. And so, this is, kind of talk to the foundation. And as I said at the beginning, I'm very appreciative of your prior kind of, kind of investment in me. And, I hope we can continue that relationship going forward. So I'll stop with that. I'll kind of welcome Dawn back on. And I thank you all very much for your attention. And I'm happy to take any questions that you might have.
Well, thanks, Dr. Oliveria. This has been really interesting. I've been working with you for a long time, and I've learned a lot from this conversation this morning too. So as is probably no surprise to you, there are tons of questions for you. So so just a reminder for those of you on the call, we have a function called the Q&A. My colleague just put it up in the window, so you can see down at the bottom of the screen there's something that specifically says Q&A. That's where you can add your question to the ones we're going to be asking Dr. Oliveria. So so just to begin, Dr. Oliveria, we've got a question here. Many of your patients have long-standing neurologic conditions. How would someone know if they're a good candidate for surgery?
Right. And I sort of alluded to that right at the end there, that I work really closely with neurologists and all those other disciplines. So the epilepsy neurologist, movement disorder neurologist, the neuro-oncologist, and the vast majority of my patients come to me through them. Because most of the conditions I treat, the first step is medical management. If your seizures can be controlled with one medicine, you don't need brain surgery, or hopefully you don't need brain surgery, particularly if it's well tolerated, that medicine. And so, typically there's a phase of medical management before the patients ever see me. And most of these conditions, they're seeing me because medical management isn't sufficient to treat their symptoms.
Okay, thank you. It looks like we also have another question here. Is the surgery effective for medication-induced movements like tardive dyskinesia?
That's a really good question that there's not a simple answer to. In some situations, yes. The simple answer, that's an off-label use for DBS. We do it sometimes. We have no other options for patients. It can be variable in its responsiveness, unfortunately. And so, it's one of those things we don't, most people aren't that excited to try a brain surgery that might not work.
Sure.
And so it's hard to know for sure. That's definitely a very specific kind of patient specific kind of potential surgery that we don't do very often. I can say that. Yeah.
Okay. Thank you.
Mm-hmm.
So we got another question here from someone who was diagnosed with a functional movement disorder over a year ago, and the traditional treatments don't seem to be helping. Is there going to be further research or testing into this branch of involuntary movements, or do you know of any trials for treatment that are going on for functional movement disorder?
Yeah, functional movement disorder, that term is very broad. It covers a lot of things. And so that's a little bit difficult to answer. I'm probably not the best person to answer that because, typically those aren't things that are treated surgically. So I'm not the best expert. It's something that neurologists know a lot more about than I do. I'm sure there are there are lots of resources. It's a common problem as well. And so, yeah, I'm sure there's sort of both research as well as lots of, kind of resources available specifically for patients with that. Oftentimes it is kind of finding the right program for you, and it's not the right, not exactly the same kind of treatment for every patient by any means with that. And so, yeah, it's one of those things that, I would definitely kind of encourage you to talk more to a neurologist than to me, and maybe kind of finding the right, kind of fit for you. Yeah.
Okay, thank you. It also looks like there's a question here in the chat that says, is Providence offering TMS or something similar to the Stanford University TMS protocol in Dr. Nolan Williams' brain stimulation lab?
Yeah, so I think that they're referring to transcranial magnetic stimulation. As far as I know, here in Oregon, that's not being offered. Not that I'm aware of, but again, I don't want to misspeak. It's not something I'd be too terribly involved with. But I would, kind of, you might look through the Providence website about that. I wouldn't be surprised if it's happening somewhere in the Providence system, if not in Oregon, maybe in Washington or California. It's something that's not done very often, it tends to be something that's still in the research phase for a lot of academic centers. And what that is for people who don't know, it's sort of, using sort of external magnetic stimulation to, you can actually induce currents in the brain, using magnets, strong magnets outside of the brain. And, it's different than kind of what we talk about, because it's something you go in for treatments and then you leave. I know it's definitely being used in particular for mood disorders like depression, and for kind of recovery after things like stroke or traumatic brain injury. As far as I know, those are all kind of in the investigational phase, so you may have to kind of be involved with some sort of trial. But again, that's certainly not my area of expertise. And as far as I know, I don't know that there's any trials like that going on in the Providence system, but I wouldn't be the best one to know that.
Okay, thank you. We also have a question here. What do you see as the future of your practice?
Yeah, well, it kind of gets back to what I was, talking about at the end. I would love to talk about my last slide for like an hour, because they have lots of things on the horizon, and really kind of, as I think you probably could tell from my talk, that certain pieces of key technology really open the door for us to do new, exciting things. And, certainly we have examples of that now, including, like I said, the intraoperative MRI suite, where I do a lot of surgeries where we can kind of do CAT scans and MRIs and surgery all in the same place. And it's really revolutionized, like I said, our epilepsy program and some of our tumor treatments. But certain key pieces of technology, open up, other ways that we can treat things. And, and I should say, I think I alluded to this at the beginning, I still do lots of big open surgeries as well. And, we're always trying to do things through as small incisions and as comfortable and as safe as we can. But, sometimes people need big surgeries too. And just having all the different things available, and that's what I really like to be, kind of confidently tell a patient that I don't think going somewhere else you'd have something available that we don't have here. And we want to be able to say that as new technology comes out and lets us do things in creative and innovative ways. And so yeah, in terms of the technology, I think there's always new technology. In particular, very interested in robotics to replace those frames that are kind of reaching the end of their lifespan, and new kind of imaging modalities that allow us to do things safer. And then again, I'm very excited to kind of start working on training, kind of fellows and things like that. And obviously the research component, which we could spend a lot of time talking about, but we'll skip for now.
Okay, thank you.
Mm-hmm.
So we have another question here. How severe does a person's movement have to be to qualify for this type of surgery? Is there a scale of severity for it?
That's a really great question, and it kind of gets back to the sort of the title of the talk was about tailored kind of surgery, because I don't think that it's definitely not a one size fits all type of surgery for movement disorders. And we have a lot, most of my patients who've had the surgery, we have a long conversation about about exactly how their movement disorder is affecting them. And really needs to be something that's affecting your quality of life significantly despite medication. That's sort of the simple answer to that question. And some people, a lot of these, especially for example, like essential tremor comes on very gradually. A lot of people have it in their even childhood or in their teens, but it doesn't become disabling until they're in their 50s, and so they've had it for a long time. And they come and see me, have this really dramatic kind of tremor that if they had that happen overnight, they wouldn't they wouldn't tolerate it, but it's kind of crept up on them over 20 or 30 years. And so, the patient who kind of has an immediate onset of bad symptoms might not tolerate it. Oftentimes those patients with those really big dramatic tremors have all kinds of accommodations they've developed in their life to work around it. And so, sometimes we'll do surgery for someone with a really fine tremor that, that doesn't allow them to do their work, as opposed to someone who, some of our poor patients who can't feed themselves because they're tremor, and they say, I'm doing okay. So it's not a one size fits all answer. There certainly are rating scales for both essential tremor and for Parkinson's disease and for dystonia, that we use those in our decision making. And I should say, someone with the really mild symptoms, that we're probably not going, it's all about risk versus benefit. And there is still the inherent risk of doing the surgeries, and we try to reduce those risks as much as we possibly can, but we don't want to put anyone in, kind of through unnecessary risk, particularly if there's other treatments, sort of non-surgical treatments that might control their symptoms.
Okay, thank you. And our next question is kind of a follow-up to that. And that's, is there a maximum age that you would do these types of surgeries for essential tremors?
Not necessarily. There are limits, and it's not necessarily an age limit, although I'm certainly more sort of cautious for someone in their 80s than someone in their 50s. But we certainly do surgery for people in their 80s, because the older you get, the more common movement disorders are. And so, many of our patients are in their 70s, and certainly, a fair number in their 80s. And, we start to look at those other things that come into play, whether anesthesia in general is safe for a patient in their 80s. A healthy person in their 80s, I have no hesitation to do surgery on. But conversely, a person in their 50s who has heart disease and kind of has lung problems or diabetes, those can be problems as well. And so most people, we can kind of address a lot of those issues and get them through surgery. But with some of the movement disorders, you start to have other problems like dementia and cognitive problems, thinking problems, and those can be much more limits to that make us worried to offer surgery than necessarily an age limitation. So, but again, we take all that into account. It's sort of a bigger picture. I should say almost all of these, actually all the things I talked about today, we have monthly or bi-monthly meetings where I meet with the neurologists, both for epilepsy and for movement disorders and for brain tumors. We all meet as a group and discuss the patients. And so you really get sort of the consensus opinion of all the doctors involved with your care all at the same time, which is really important for this, because, obviously the neurologists oftentimes know the patients a lot better than I do. I meet you and kind of try to decide about surgery. And so I really, rely on their kind of insider information about you. And we all kind of try to, decide if it's safe, and if so, what the right kind of approach is. And that's how we really tailor the individual surgeries.
Okay, great. Thank you. So we've received another question about DBS, and that's how does DBS do in helping Parkinson's patients to walk in a coordinated manner?
Oh yeah, so that's another that's a great question. It's a loaded question, one we talk about quite a lot with DBS for Parkinson's. So walking with Parkinson's is a big deal, and almost everybody has problems with that. And so it's a complicated answer, but the short version of it is that DBS isn't helpful for balance specifically, unfortunately. And there's been a lot of kind of research on that if your kind of brain has difficulty understanding where the horizon's at, the gyroscopes, your inner ear, if you can't you can't really gauge the horizon, or you're dizzy all the time, it's not very good for that. It is good at making you move better, and kind of more fluidly, and and not so much of what's called bradykinesia, slowness. And so it can be very helpful for making you better able to catch yourself if you're going to fall, because your muscles are working better and you're moving more fluidly. But it's not necessarily good for specifically for unsteadiness. So that's very patient to patient, that some people it makes a huge difference in their walking, other people don't have any improvement at all. And so we really go through that, exactly why you have problems with your walking. And the other kind of issue that's very common for Parkinson's disease is freezing of gait, and it doesn't help specifically with the freezing, unfortunately. And there have been several kind of trials at stimulating other parts of the brain specifically for freezing, and there's actually ongoing trials now for other kind of locations in the brain to treat that symptom. And as far as I know, so far none of those have panned out well, unfortunately. So it's really good for the motor symptoms of Parkinson's disease, tremor, stiffness, kind of slowness. It's really good for those. It's good for dyskinesia, which is, people who have that know what that is. I won't go through that right now, but all, a lot of the motor complications of DBS, of Parkinson's, is what DBS really is helpful for. And fortunately, some of the other non-motor symptoms, the other one, kind of thinking problems, kind of dementia, doesn't help with that, unfortunately. And there's lots of ongoing research into how to, address some of those other symptoms. But as for now, it's really primarily for the motor complications of Parkinson's disease.
Got it. Okay, thank you. Well, and I think we have time for just one more question, and this one is also related to DBS. And the question is there a time limit for repositioning DBS electrodes?
No, I don't think so. Kind of, other than to come back to all the same things we talked about, that, I almost look at kind of repositioning surgery as, kind of go through it again as if you were a brand new patient. Obviously, extra kind of layer of complexity. You already have electrodes in your brain. But, it's sort of the same things. Are you safe enough to have surgery? Do we think there's a high likelihood we can make you better by repositioning it? I should say it's not something we do very often, particularly in my practice, and all DBS surgeons, we do go to great, kind of efforts to put it in the right place the first time, because coming back is a big deal, and especially putting someone through another surgery. And we do it rarely. But if we feel that the electrode is mispositioned, then I'm eager to replace it, to put it in the right spot. Thankfully, that it's exceedingly rare. But sometimes things can happen, and in particular, I occasionally get patients from other centers that are interested in that, and I'm happy to kind of to entertain that, because there's nothing worse than going through all that trouble and not having it help you. And sometimes it's a big part of that conversation is going through all the things we talked about. Was this something we didn't expect was going to get better in the first place, or is it something that gosh, we're just not getting the full benefit because it's not quite stimulating where we want it to? And then differentiating between that can be difficult. And it's certainly, if we're going to kind of put you through another surgery, we want to make sure that there's a good chance it's going to help you.
Great. Thank you. Thank you for your response there. And thank you so much for your time today, Dr. Oliveria, and for your presentation. And I just want to thank all of you who are on the call today for your interest in this important work. We have many patients who've chosen to express their gratitude for their care by making charitable gifts in support of Providence's neurosurgical program. And as Dr. Oliveira mentioned, much of the work of he and his team is made possible through philanthropy. If you're moved to express your gratitude with a gift to the neurosurgical program, or if you have questions about today's presentation, my contact information is on the screen. And if we didn't have time to answer a question, or if you have a question later, you're welcome to use my email for that as well. Just a reminder to be on the lookout for an email from our team with the link to today's program, and feel free to share today's program with your friends and family. It's also going to be hosted on our website as well. So if you lose that email, you can look for it. And today's talk is part of our 2022 Providence Doc Talk virtual series. In our next Doc Talk, which is in October, we'll be hearing from Dr. Christopher Darris on the topic of gynecological cancer and the power of immunotherapy. You can register or get more information at providencefoundations.org/Doc Talks. Thanks again for joining us today, and I hope you have a great afternoon.